auditorium and the last one to leave, always sit on the front row and have some comments. Positive he will tell, and the negative he will criticize, he will tell it in person. So he had called me to his center for his 50 years departmental celebration, and that time he organized one interview for me. And after this interview, I had got a lot of calls whether you will be do this and this. So this is some sort of an advocacy that people came to know that you are doing what, and they don't know. And with this, so this is one way of advocacy, that you need to tell people what you're doing, because you may not know what your own colleague is doing. So with that time only I was to have a conference. So my conference theme became advocacy and mass education, because as we know, plastic surgery people think is cosmetic surgery only. So you need to educate people about that. So nowadays we have seen we heard Dr. Ayer's talk also. The future, I think, is high specialization. It is robotic surgery, tissue return glue, and robotic. And this is the most viral. And this, I think, will happen one day. So this is an head transplant. But I can say that head transplants were done in our country much before this. Ganesha is one example of this. And as you know, Ganesha is a clone of Parvati. And when Shankara came after some time and he wanted to go and he didn't allow, so he got angry and he beheaded the child. Afterwards, when he realized it was his own son, but by that time, the time was past. The brain cannot survive ischemia. So you cannot kill any other human being. So he had an elephant's head which he put it on the Ganesha. So that's the first heterogenic transplant that's been done. I think we can claim that we were the first to do it. There's the cloning, which is a reality. And now the transplant, and this we take it as he has a third eye, which is laser. He has snake, that's a chemo, and he has his pint as a radiation. So he covers everything about onco as such. So this Ganpati was not allowed to go out because of his immunosuppression, so he became fat and he used to stay at home. But this has to be propagated and told everywhere. So Kartika used to go out. So now they are building a temple of, I think that was inaugurated last week in Thailand. That's even Shiva required an advocacy with Damru. His gun used to go and advertise that he is coming. So if he needs an advertisement, even advocacy, even I think we also need to do that. Everybody needs to know what is oncosurgery, what is reconstruction. So what is advocacy? Advocacy is defined as any action that speaks in favor of, recommends, argues for a cause, supports or defends or pleads on behalf of others. That's the dictionary meaning. In our aspect, it is like informing everybody what we can do. And mass education refers to a system of education that aims to provide formal learning opportunities to large number of individuals at a given time. This is AI generated definition, but these are all the sources, different varieties where you can generate. It's a television, because mass media is the best way of propagating anything now. Those are television, radio, newspapers, your articles in the paper, your articles in journals, internet. I think Instagram and WhatsApp, I think that's, or Twitter, it is doing wonders if you want to spread something across. So this provides, even nowadays you can say your knowledge is at your fingertip. On our Guru Purnima day, it is not your gurus. I think it is the Google Guru that you now worship. So, but without involvement of masses or the general public, no health project can be succeed. Our science is growing so much, almost it is becoming super specialization in our own branches, which sometimes our own colleagues, like today I learned quite a lot, which I was not aware of. So that is possible. So like, give an example of Modi. He about Swachhata Bharat, he put it a competition that what logo you should have. And in that aspect only, I think he got thousands. So that was kind of an education by itself. And then that logo was formed. And then he had other media also, he used it to propagate that, and now it is Swachhata Our Sanman. Similarly, for Corona period, I think with our population and our kind of economics, he did quite a good job of curtailing that also involving masses in taking precautions. Then polio eradication is another example of advocacy and mass education. When the program started, the ladies were quite reluctant to go to just to have, it was like 2 boond zindagi ka. They had to involve a celebrity. I think this celebrity, when he was saying that, but then still ladies were not coming. So then it was said that the Piyush Pandey, he told him that you have to say it little sternly that only 2 boons zindagi ka. So those ladies then started coming because they didn't want to displease Amitabh Bachchan. Okay, and that became a successful program, and almost like polio is now eradicated. There are various programs, various days we decide. On these days are not that you go only on one day you celebrate it. People's memory is short-lived. So you need to have these days so that you can have programs, you spread more knowledge, which is the general public can absorb it much in an easier fashion. So there was a national tobacco program which was instituted in 7 and 8. I think this is head and neck cancer killing. This implemented control about tobaccos, what are the drawbacks, and they have those printed on the cigars, that what sort. I think you go to a international airport and go to a cigar shop, you will have an encyclopedia of diseases, because that's everything is printed on the cigar boxes. Then they started a national oral health program, because I think most of the head and neck patients, I mean, usually they will have some ulcer or some problem. So dental people should be aware that the thing that doesn't heal within 2 weeks with a conservative thing, you should suspect that there is a malignancy, because they are the first one to see it. If they direct patient at that stage, I think maybe we will then become jobless, because there will no reconstruction will be required, because they will be caught at very young stage. So these need to be they need to be briefed properly what should be the thing, because many times they are told nothing, don't do it. And I find Dr. Chaturvedi, when I joined Tata, since that time, he was much for anti-tobacco. He had lot many with his colleagues, other friends. He is vehemently after it. So that is one gentleman I knew who is doing a good amount of work to avoid tobacco. All these days, like I said, we celebrate Plastic Surgery Day. That day we conduct some camps, we have some lectures, some posters. Like that day, there is a World Cancer Day on 27th each year. So that's the global can. I think in ladies, breast is the most common cancer, and in males, I think oral cavity cancers are more predominant. That's the Globocan scan. And they also have come out with different posters which are displayed everywhere. Now I think with their help only, the public smoking has stopped. Now you don't get passive smoking. That is one very good thing that has happened. There are some posters like this available. We plastic surgeons also need to tell everyone what we do, because we are usually labeled as problem solving specialty. Though we get involved from head to toe, as we are not organ specific, patients don't know where to go. And then you get them when some complications have happened. Aware everyone that such brochures you can distribute, or you can put it in your waiting room, or you're going to different hospitals. So what all is possible. The pictorial thing has more lasting memory. Audio visual lasts much longer than just hearing something. So you can have posters or the photographs which are displayed. So what all we can do, you can distribute in general public, schools, wherever lectures you are taking. Have some banners which says this is about burns. This is how water or fire. I think it has taken since my childhood. I'm hearing the pour water over burns. I think now people have adjusted to that pour water over bones. I think anything you say repeatedly gets embedded and you retain it somewhere. It's like you go to a shop and you want to buy something. You don't know what to buy. And they say, "Arey, we have heard that, so please give me that." So that's what is marketing and making people aware of the brand or the value. So these are displayed on the railway stations. These are like different things happening all across the railway stations about burns and other things. Like Ravin Thatte is writing short notes. What if short notes he is writing? I think they are very simple and understandable by even lay people. I think it's about 300,000 people have visited his site and he's so far written about 84 chapters. So that makes aware of the other people also about what plastic surgery. And Nikhil Panse, he has started an plastic surgery education platform with his colleagues on the YouTube, and he had different things on the YouTube. I think similar things we need to have for the onco reconstruction also and the cancer also. So if we do that, then the awareness will be better. But only one day may not be adequate. So you need to, we celebrate in Tata, we used to celebrate for about almost a week that one day you have a quiz, because undergraduates quiz, sister syndrome, even PG students, not many of them, then they realize what all aspects of plastic surgery is. It's not only cosmetic surgery, it is, I mean, I can't enumerate everything that is there. When I had done plastic was this much, now I can't encompass in my hands. This is one such idea. It came from sisters. There was a breast program. Can you have sound? This is a one delicate issue, how to explain breast examination. But they came out with a simple idea. They had an template which they put it, and the lady explained how you palpate and how you do it. So such a delicate issue was explained in public to everyone. So the ladies become aware what sort of an examination needs to be done. So it doesn't have to be such ideas. You use it for head and neck, that you eat tobacco, you get this ulcer, and how when to go to a doctor, to a head and neck surgeon.
पिंपल क्रैक है कि नहीं, मतलब उसकी स्किन जो ऐसे क्रैक हो जाती है वो देखेंगे हम लोग। फिर उसके बाद हम लोग आएंगे तपासने में। तो तपासने में हम लोग दो प्रकार से कर सकते हैं। एक तो हम लोग
So she explained everything about how to palpate. So this was not an exactly a person in front. You have a model and you do it.
सर्कुलर मोशन में जाएंगे। तो सर्कुलर मोशन करते वक्त हमारे उंगलियों के जो पैड रहते हैं।
I think I'll go ahead. The head and neck now, I'm specifically going to head and neck because that's the most, though it's a very small part, but it is functionally packed region and your face is identity to the society. Anything abnormal to that individual, it puts a setback for that individual to go in the society. And person doesn't like to go and mix up with others if he finds that. So it change from its normal reduces his self-esteem. As we all know that the surgery is the mainstay of cancer, chemotherapy, radiotherapy surgery. It's a multimodality treatment, right combination, right sequence and right time. So there is a time constraint. Cancer now, if detected early, is almost curable. Hence, everything boils down to the quality of life. You can't say that I've removed the disease and give him a deformity and you say you are cured. So what next? So unless you give a holistic treatment that he can go back to his normal occupation or he can share his life with his family and friends, you are giving him a life but which is without life. He just lives on. There is no quality in that. Now with the advances in our technology, replace like with like has almost become a reality. These are the different ways. You have now CAD-CAM, you have the perforator marking and everything, and you can literally give customized reconstruction. When I was at Tata, I used to say that we are giving the mandible, I am giving you my mandible, because it was cosmetically and aesthetically acceptable mandible. It was not patient's original mandible because we used to use the KY template more, not use CAD-CAM or stereolithic model and do the exact cuts at that time. But now the era is there, you give a customized reconstruction to the patient, so he almost forgets that he has undergone a reconstruction. I had a person in my society who came, he was operated in 70s, and when he heard that I am doing reconstruction, he came one day and he said, "Can you do reconstruction?" He was a hemimandibulectomy patient and he asked for a reconstruction. I said, "After 25 years, why you want reconstruction?" So he said, "See, my grandchildren don't come to me." So that was his issue, that he wanted a reconstruction. Primary reconstruction, I think, is standard of care for any head and neck reconstruction if reconstruction is needed. To do a secondary reconstruction after radiation, I think I'll think 200 times before I put my hand in that. If disease is there, you have no choice. But if disease is not there and he has received radiation, nothing moves as I want it to move. Like I had done one middle third mandibulectomy patient, secondary reconstruction. We did the secondary reconstruction, it survived well, but the tongue which sags down, you just can't pull it up and come up. So the tongue behaves like it is in a well. So whether we did a justice in doing secondary reconstruction, I don't know. So that's why I think primary reconstruction, whenever possible, should be the norm. Whether it is for patient is going to live for 1 year or patient is going to live for 10 years. I think many times we say that the disease is very small, won't require reconstruction. But I think when the disease is very small, I think you should try to give the best to the patient because his longevity is more. But even in advanced cases, if you have planned the patient for surgery, I think you should not compromise in what you give to the patient because his quality of life, whether it is 1 year or 2 year, will be better than you give something below standard. So the longevity should not be. That criteria comes in a high volume center where you do a triage. But where that load is not there, like in Tata we say posterior segment, just forget about it. That can be done with an PMMC or a soft tissue flap. The middle third or the whatever process your midline will take the priority. So that many times, but posterior segment is removed for convenience. Once we started discussing, they don't have to remove the condyle and the subcondylar portion. Then the functionality becomes very different. That's why the joint consultation, like what Dushyant said, that you talk to the patient, talk to the operating surgeon, and they knew what it is. So you can plan accordingly. What happened? Not moving forward there. It's not moving forward there. So whenever we plan a patient, we have a joint discussion with the operating surgeon. It's not going ahead. Here it is going ahead. There it is now. I will show you few patients. Like I used to say, learn 3 flaps, okay? When I joined Tata, I think the thing was close the wound, whatever best we could, and do more and more cases. So that time we used to do, then I said that learn 3 flaps, you can manage any defect from head to toe with 3 flaps. But now over a period of time, your armamentarium has increased and it has to increase to give the best. So you have to judge what is required, what's the donor area, and what's the defect that you need to supply that donor area, whether it gives or not, whether you require 1 free flap, whether you require 2 free flap. You do whatever you need to do for that patient without thinking what's next patient I need to take. Once the patient is on table, it is our duty to give him the best. So this is one such lady where the flap was done. Sorry. Where the upper lip is gone. I think upper lip gone separately, lower lip gone separately, reconstruction is not very difficult. We can still give a very functional lip. But when both the lips are gone, that's the most difficult reconstruction that you can come across. This is well settled patient. But like any defect that you assess, whatever is close to the lip, you require thin pliable skin. Whatever goes slowly laterally towards the angle of mandible, your third dimension starts coming. Whether the masseter is the RMT lesion, masseter is gone. then you require a bulk to feed over there. If you put a thin flap, initially it always looks nice because there is a lot of edema. Any patient you do it, after 2 days it looks very nice because the edema sets in, and as the edema settles down, your depression starts coming in. So you need to judge that and feed the flap. Like tongue, what we aim at what we want. What we reconstruct, we always tell patient that our job is 50%. Your job is 50% to get your function back, your speech and eating. If you tell them that, like in total, this is such patient, this is the defect, that reconstruction effect that we want to have, that they can go back to their original occupation. In total gloss, you need volume. That's where a bulky flap will come, whichever it is. If the PMMC is bulky or the ALT is bulky, you put it that. Such patients, if you tell them that you will never be able to chew and eat, that will put their morale down. So even if they have 32 teeth, they won't be able to chew and eat because your anterior two-third of tongue is like a finger in the mouth, which brings the food below your masticatory teeth. But if you tell them that, they will get discouraged, that I won't be able to chew and eat. So that puts a setback. See, so then you tell them you may be the first one, miracles can happen. You try hard, maybe you will be the person who will be able to chew and eat. Then you get their cooperation. They see such patients, and the other patient, they'll convince that they can come for surgery. Like mandible. You have to wait. We talked about the lower lip defects. This is before artist photograph. Okay. After RT, it may, like I say, flap and flap shrinks down. This is chimera. We realized that we used to do deepithelialization and bring it out, then you will have some niggles, marginal one, but that used to set back. We realized that we see too many perforators, so why not dissect perforators, divide them, and then use it, so they survive much better than deepithelialization, because deepithelialization itself will require little extra flap for it to fold out. This is maxilla. If not reconstructed, he will have a sunken lip and he won't be able to chew and eat. There is a feasibility that you can put dental implants, but like we said earlier, that dental implants are not done very frequently. Though we say we aim for the final rehabilitation, it is very few people will reach to that stage. So basically post RT. This is young patient where the small segment, because his longevity and young patient, it was not a malignancy, it was amyloblastoma. So this is how it is growing. Like pharynx reconstructions, you are giving the patient the swallowing back, whether there's always a debate whether you should do jejunum or a skin line tube. Like the trend is going towards now skin line tube. Though I saw a good presentation by Dhanush where they are using a jejunum still. So our patients are our best advocates. So they will, if you involve them in your thing, like many times the breast patient comes, you explain them about the reconstruction, and then they say, can we see a photograph of a previous patient that you have done? But then each patient is different, each patient will behave differently. So showing a photograph, maybe their expectations may increase. So then we tell them realistically what will be the thing. And they need to accept that what are the complications. That also we always say that this can happen. So that is breast, like head neck reconstruction is a norm, while in breast reconstruction is a choice. You want to have reconstruction is also right. You don't want to have a reconstruction is also right. There is nothing right and wrong in breast reconstructions. It is how the patient perceives her body image that she would like to go ahead with reconstruction, whether it is, then all different options we will explain. But then they will ask you, what would you prefer if I would have been your relative, your daughter or your mother? Initially, I used to say, why should I take that responsibility? Let them decide what you want, you decide, I will not take that call. Then one fine day, one of my students, he said, no, madam, I always tell them what is best, that I will do it for my relative. It is their choice whether that they want that best or they want the second best. Then I agreed with that why should I hesitate in saying what I will do it to my relative? That's what I will do to somebody else. Like patient come and says, I want to go in private, then they have an impression that you go to private and pay, you will give more attention to them. But then we tell them that whether you stay in a deluxe class or in a economy class, your ambience changes, not your treatment. Your treatment will stay same, whether you're paying 2 lakhs or whether you're paying 10 lakhs. Only ambience changes and you may be pampered little more, that's all. Nothing changes else. So they need to then take a call, because cancer is such a thing that it doesn't stop at surgery alone. They may have an chemotherapy, radiotherapy, regular follow-ups, regular CT scans coming from far off. We feel that it is only 5 lakhs to him, but there is a hidden expenditure to the patient. When he comes from far off, he never comes alone. He always comes with somebody, stay somewhere. And as a patient, you cannot go and stay in somebody's house for 2-3 months time or something. So you need to take into that consideration also. Motivating these patients, form a group. Like breast people, I think they have formed a group. There is a breast working group where they advocate, they have programs, they have marathons. So awareness is there about breast everywhere. In head and neck, if you, many times patient come to us, is my face going to be like that patient who is sitting outside? Because that was an extensive defect. You have tried to do best, but still you will have some deformity seeing it. Is it going to be like that? I don't want it like that. Okay. So you can form a group, and those groups themselves can communicate with each other what problems they have, what they can expect, and how it is to be done. There was a very good symposium in one of the European Congress. You say you are cured. What next? Because we feel that we have done a flap, we have closed it, and he is good. But he has so many other problems which we don't realize what he is facing. So for that also, I think we need to discuss, we need to find some solutions. So many times patients themselves can talk with each other and find solutions. So like you have a patient who is drooling from here, the lip has not come out. But when you ask the patient, we see the thing and we ask the patient whether you sit with everybody and eat or you sit in one corner and eat. He says, no, I sit with everybody and eat. Do you drool? He said, no. So he had developed a trick movement that he will bring his tongue over there while swallowing. So nothing will drip. So such trick movements also, they can be very helpful, which we don't realize that that is possible. So that is one way of educating other patients. So we need to, used to say that blow your own trumpet. One of my seniors said, you have to tell yourself you blow your own trumpet. Why should anyone else will bother to blow your trumpet? So you have to say that. But what I feel is that telling and putting it in papers, there is a very thin line between an advertisement and advocacy. So you need to balance that. You should not fool that you are advertising yourself. So it should be an unbiased thing over there. So it is not only Damru that you need it now. It's not even a band, because specialty has grown so much that I think you need now an orchestra or something like this for to have millions to gather and to get the information. I think information told in such a way is digested or retained much better than just talking to them. Visual impression is the lasting impression. And you need to take patient in confidence, because they come with unrealistic expectations. I'll be able to chew when there are no teeth above, there are no teeth below, there is no joint. Then you say maybe you try something and you will be able to. Sometimes when the mouth, if we tell them upfront that if the mouth opens, we'll put bone. If mouth doesn't open, there is no point in putting bone, because you can't put teeth between it. But then later on, if you say that it's not possible, so they feel little cheated. So you have to be frank with the patient, what to expect, not to give them over expectations that everything will be normal. I have seen people, kuch nahi hoega, sab theek hoega. And they get carried away. And if you say this thing, they say you don't know anything, they will go to some other person. Maybe the other person may be better than you don't know. But that's, my teacher used to say that patients come to you. You can't choose your patient. You need to prove to the patient that he has taken the right decision by doing whatever you need to do, anytime, every time. So that patients, at least you go home satisfied that I have done my best. So every time you want to do a surgery, I think you should think that this is the best surgery of your life that you are going to perform. Then only you will try to give your best. And non-planning is plan to fail. So each step that, like Aklan said, you rehearse in your mind that you are doing that steps. So like you are giving a talk, you will start with, I'll speak this, and somewhere you again miss it. Okay, and then you realize we have not done it. So that cannot happen in surgery. See, you plan it well. I tell my students to read every surgery they are going to perform. You will get something more in that. Plan meticulously. Microsurgery or a free flap is not only the solution. Like Dr. Mehta's talk, your local options are also equally good enough. So you need to balance between free flap, local flap, whatever gives best for that patient. I think you do justice to your surgery that day. It's not that I want to do free flap only. But sometimes in a complicated situation or something, your mind just gets blocked. You can't think other way around. Then your colleague is there. So you need to just take off your gloves, go out, have a cup of coffee. By that time your tension goes, your bleeding stops. And then you can chat. Now everything is available on WhatsApp. You can contact anybody. You can get the best solution from your junior most. So keep your mind open if you are stuck somewhere. That's why you should have a team. Team is of your understanding. So if you have a team, I think in a microvascular setup or a free flap reconstruction, we are doing long hours of surgeries. I think it should be a teamwork. Otherwise, you will burn out yourself much early in life. And it should be a teamwork, like onco team, totally separate, reconstructive team, totally separate. Because I used to be asked in OT, Prabha, should I save this for you? So I used to say, sir, don't do that. Whatever you need to remove, you remove. Don't save anything for me. Whatever is required, I'll do it. You don't have to do, but don't remove something for convenience. Like many posterior segment mandibulectomy used to be for convenience. So they are being now converted into an segmental, where the functionality totally changes. So it is a open mind to accept ideas, read knowledge, attend such workshops which are dedicated. Attending general conferences are like, nowadays I'll call it a social gathering where you have not met people, you will meet them after a long time because it's huge. You have 5 halls, 6 halls to attend, you don't know where to go. Concentrated workshops will give you good ideas, clear your doubts, and give you confidence. Just now I was talking to somebody, he said initially when I started doing free flaps, there was a big there was a big aura about microvascular surgery, that microvascular surgery is very difficult. Not many people used to venture. But then I started doing onco-recon workshops. In that, there were people who were new, there were people who were already doing it, but they have some doubts, they have some hesitation, they have a lack of confidence. But when they realize that microsurgery is one small part of your procedure, of course, that is one of the important part of the procedure, but there are so many other things that you plan, how you go about it. Simple thing like an intraoral closure. You have to be very careful about intraoral closure. If that's not done well, whatever good job you do may go down the drain because of the oral communication into the neck. And your anastomosis may be very perfect, but because of OC and because of the infection, that you will lose that flap after 5-6 days, and such flaps are not salvageable. So your meticulous steps during surgery are very important. Don't take anything lightly. Like we say donor area, we just leave it to somebody to close it. And you saw the photographs of so many donor area problems. I think simple things also require attention. Like I say, whoever is the junior most, whoever is there, everybody needs a respect, whether he's a senior or he is an peon in the office. So do everything religiously, meticulously, each step, thinking that he is your own relative, and then follow it up. And this needs to be told to everyone, that look at the patient as a human being. Don't look at only the defect, that this is the defect. One of my anesthetists has said that how you take around in ICU. You come, you say patient good, flap good, you go away. Second, you will say patient on inotropes, flap good, you go away. Third, fourth day, patient maybe no more, or he's very serious, flap good. This is how you look at it. So you need to see patient as a whole, how much is BP, whether he's maintaining it or not. Everything matters. And this also, like we need to tell our juniors also that these are very important steps, that you look at the BP. Like head and neck surgeons usually want an operation under hypotensive anesthesia so that there is less bleeding. But when you are doing flap, you want a normotensive patient. You want to see the bleed in the recipient vessel, and you want to see the bleed on the flap. And if you don't do that and you close the patient, and later on the BP comes up, something which have been coagulated with a bipolar or a lega clip or something just opens up, and then you have a big hematoma. So, and where we put it in, everything matters in these procedures. So you need to be very careful in each step. Don't think that microvascular ho gaya to we now I'm done. One of our anesthetists asked, micro ho gaya, so he used to think micro ho gaya means sab ho gaya. But micro ke baad you wait for some time and you do suturing. And then you see that everything is all right. So we do a first prick of the day on the table that you can monitor it afterwards to avoid complications. This everything is taken for granted, but it needs to be done, and that needs to be inculcated in everybody who is working with you. Then only you will get a good result. And this needs to be told to, from sisters, everybody, what to look for. Then only we will have a good outcome for the patient, and then you feel right, because I don't think there is any person in the auditorium, maybe there is somebody who he didn't have a flap loss or a complication. But if you have taken proper steps and done it properly, you don't feel guilty that, hey, I forgot that and I left it, I should have been there. You are answerable to yourself, so try to do justice, try to teach people around you why you are doing what, then you expect good results. So advocacy at each stage. This workshop itself is an advocacy, because so many of you are knowing what are the local flaps that can manage. Every patient doesn't require a free flap. How to use the best of both the worlds, and then try to take your decision. I think enough of an advocacy now. Thank you for your kind attention, because this is, I take a lunch, I feel sleepy. If I would have been sitting there, I would have been feeling sleepy. So thank you very much.